And here we go. So the pattern of activity of the heart is set or determined by the pattern of electrical events that I just described to you. So let's talk about the pressure and volume changes involved now. So to start with, we want to talk about some just very general sort of terminology around the heart. So systole and diastole are two of these. And these are just used to refer to the state of the chamber in question, which is to say, is that chamber contracting or is it relaxing? So systole equals contraction, and this is the time during which blood is ejected. So if we're talking about the atria, that means blood are being ejected into the ventricles. And if we're talking about the ventricles, it means blood is being ejected into the pulmonary trunk and into the ascending aorta, respectively. Diastole is relaxation. So this is the time during which relaxation means that the volume in each of these chambers is getting larger. And as you probably are aware, pressure and volume have an inverse relationship. So the lower the pressure, or like the lower, excuse me, if you increase volume, you decrease pressure is what I was going to say. So higher the volume, lower the pressure. So if a chamber is in diastole, what that means is it's getting bigger, which means that the pressure in there is going down, and that creates suction. So diastole and relaxation and the suction it creates actually encourage filling of the ventricles specifically. So blood flows due to differences in pressure, and it obeys the same rules as pressure flow in general, which is things flow from an area of higher pressure to an area of lower pressure. That's not hard to understand. Okay, so let's look at this whole cycle from front to back, and then we will also observe a particular image that you should become very familiar with that shows you the relative times during which a bunch of important cardiac events occur. So if you look here, you can see milliseconds again, and note we're going from 0 to 800, so 0.8 seconds. So at time 0, we get depolarization of the SA node, and then that's followed by depolarization of the rest of the atrial myocardium, which is followed very, very shortly thereafter by contractions. That's when atrial systole begins. Once that 100 millisecond delay has passed, then we get atrial systole ending because atrial diastole is beginning. So the myocardium is beginning to relax. It's not depolarizing. And so it's going to have negative pressure, and that's actually going to help draw blood into the atria via the veins. During this time, the pressure inside of the ventricles is growing. So the ventricles are full of blood. The excitation has spread throughout the ventricular myocardium, so these cardiomyocytes down here are beginning to gain tension. But at first, the pressure in the ventricles is not enough pressure to open the semilunar valves. Specifically, the way that the semilunar valves work is that blood falls back down and fills the cusps, and that is what holds the valve shut. So the pressure in the ventricles has to be at least equal to the pressure of the blood holding the cusps shut in order to begin opening the semilunar valves. So this phase during which we have an increase in pressure but no change in volume because blood's not being ejected yet, this is called isovolumetric contraction. Iso means same, volume means volume. So isovolumetric contraction means a change in pressure and contracting without a concomitant change in volume. So as the tension continues to rise, ventricular pressure is going to eventually exceed the pressure in the arteries, and the semilunar valves will open. So now we're past isovolumetric contraction and we're into ventricular ejection. And after that, we get ventricular diastole. So this is the period during which we have isovolumetric, same volume, relaxation. So the ventricles are relaxing, but they haven't quite relaxed enough to open the atrioventricular valves again, because the pressure down here has not yet fallen far enough that it's below the pressure up here. So we have two kinds of isovolumetric things. One is contraction, the other one is relaxation. All right, and then if we go back up here, once the pressure in the ventricles falls low enough that it's less than that in the atria, then we have all of the valves, all of the atrioventricular valves anyway, open. So blood is going to be passively via venous return flowing into the atria, but not staying in the atria, it's also flowing into the ventricles. This is what I mean when I say passive filling. And then the cycle starts over. So if you pay attention, you'll notice that this chart also contains rings that describe atrial systole and atrial diastole. Notice that systole is always shorter than diastole. And then also when each of those things occurs. Okay, so this particular chart is related to the one I just showed you. It just traces things out differently. So this is showing you one cardiac cycle. At the top here, we have our EKG. So atrial depolarization, ventricular depolarization, ventricular repolarization. And then in this grayish box, we have pressure. Here we're measuring pressure in millimeters of mercury. Obviously, that's only one measurement for pressure. You could choose others. But in this case, we're measuring it in millimeters of mercury, so that's what we're going to stick with. So we've got pressure in the aorta, pressure in the left ventricle, pressure in the left atrium. Why only the left? Well, the left side of the heart is the side that feeds the systemic circuit and therefore directly keeps you alive. So it's not that these pressure and volume changes don't happen on the right side of the heart, they do. It's just that we report and measure them on the left side because the left side is where you get your lifeblood from, literally. So one thing to note is that we get atrial systole in this box starting after the onset of the P wave. So you can see this line falls right in the middle of the P wave. That's because you have to depolarize first before you can contract. If you pay close attention to ventricular systole as well, you'll see this line corresponds to the middle of the QRS complex, not the start of it. So this is important to keep track of because it's physiologically relevant. The ventricular diastole onset does not happen in the same middle part of the curve, it happens toward the end. And that's mostly just because there's so much ventricular myocardium that it takes a while for it all to get to diastole. So that's the reason for that. Okay, pressure in the aorta. Obviously, it's going to fall as blood is leaving and going out to the capillary beds. And then once the aortic valve opens, we get this big increase because blood is rushing in. At this little inflection point here, 6, the aortic valve is going to close. But then the pressure goes up a little bit before it goes back down. So this is called the dicrotic notch. The dicrotic notch is present after the aortic valve closes, so you get this little recoil because the atria is elastic. So blood falls back down the ascending aorta and momentarily pushes on the walls of the ascending aorta once more, where it had previously been just moving through. And that causes a transient increase in pressure. So you get this little boing going back up before that blood fills up the valve cusps and shut the valves, but also flows into the openings for the coronary arteries and therefore takes the pressure in the aorta back down. So that's the deal with the dicrotic notch. We also have volume. So this is volume in milliliters. Now, volume in milliliters here, this is representing only the left ventricle again. And remember I said the left side is measured because it's the one where your literal life's blood is being moved into the system, thus keeping you alive. It's not the case that the right heart isn't experiencing these same events. And in fact, the right and the left ventricles move the same volume of blood. So this milliliters, 130, you can expect the same amount of blood to be moving in and out of the right ventricle as well. Okay, so this is in the left ventricle. So we have passive filling, passive filling, passive filling. And then if you pay close attention to this line, we have atrial systole. So from 2 to 3, this is atrial systole filling the last little bit of blood into the ventricle. So it's not responsible for all of ventricular filling, not even close. The atrial systole basically just puts the finishing touches on filling of the ventricles. So at the end of ventricular diastole, so if you trace this line down, 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 you'll see here we have ventricular diastole ending. So we call this volume the end diastolic volume, which means the volume in the ventricle at the end of diastole. Now, why is this important? Well, it's a determinant of heart function. So your heart is only capable of moving the amount of blood it receives, which means that if venous return is poor, the end diastolic volume is going to be crappy too. So it'll be lower than 130, maybe something like 100 or 90. That means that it can only move 100 or 90 milliliters worth of blood, and that creates a problem. So EDV is important. Once ventricular systole begins, you see this massive increase in pressure in the ventricle, and that corresponds to a loss of volume. So again, pressure high, volume low, and the converse is true as well. Volume and pressure have an inverse relationship. So the lowest volume achieved by ventricular systole is called end systolic volume. So that's how much blood did you manage to squeeze out of the heart while you were actively doing systole? So looking at end systolic volume tells you about efficiency of heart filling. Looking at end diastolic volume allows you to make inferences about filling effectiveness. Looking at end systolic volume, so how much blood is left over after systole, is going to tell you how much efficiency the heart is showing on terms of its ability to move blood. So of the blood that it received, is it moving some, most, or not very much of that blood? So for example, if you had somebody who had damaged left ventricle due to myocardial infarction, would you expect their end systolic volume to be higher or lower? Think about it. If your left ventricle is damaged, that means that it can't contract as well, right? So that would mean that it wouldn't be as effective in moving blood out, and therefore end systolic volume would be higher. So this is an important thing to kind of keep track of, is that filling and emptying of the heart are related. Heart can only move as much blood as it receives. Okay, so I talked about passive filling a bunch before. I just want to recapitulate it. So most ventricular filling is passive, and that's because atrial diastole and relaxation lasts a long time. So atrial systole is pretty short, and it only accounts for the very last little bit of blood making it into the ventricles. So that contribution amounts to only about 30% in actuality. So 1/3-ish. Oh, and someone is asking a very good question, and that is, if one side is damaged, does the other side step up to help? And the answer is unfortunately no. So accumulating heart damage in the form of, for example, scars on the heart, like from myocardial infarctions, if you accumulate damage, it actually puts the work of the heart out of balance, and you end up with heart failure that is restricted to a particular side, or problems that are sided in nature. So towards the end of this, I'll talk a little bit about left versus right-sided heart failure, and you'll get some more insight into the question that is being asked. It's a very good question. All right, so what happens at the end of atrial systole? Well, it coincides with the end of ventricular diastole. So if you look right there we go, got my cursor back, it was going AWOL for a second. Atrial systole ends, and then ventricular systole begins. So end diastolic volume is the theoretical point at which the ventricle holds the maximum amount of blood, not of all time, but for that particular cycle. So we talked about isovolumetric contraction, and this is just the time during which the pressure in here is rising, but it's not large enough to open the semilunar valves yet. So no blood actually moves. We don't have a change in volume yet, just a change in pressure, which the name reflects. So no blood movement equals valves shut. But what closes the AV valves? Well, it's just the blood pushing on the valve, which pushes the cusps together. Then the tendinous cords and the papillary muscles help to hold the valve shut. So again, important distinction to make. The papillary muscles and the tendinous cords do not shut the valve. Valve shutting happens passively due to pressure changes. They are just holding the valve shut. Okay, so the second phase is ventricular ejection, and that is when the pressure in the ventricles exceeds the pressure in the semilunar valves. Now, just because the two ventricles are moving about the same volume of blood does not mean they generate the same pressure. So remember, when we were talking about gross anatomy of the heart, I mentioned that the left side of the heart is considerably thicker walled than the right because it has to overcome systemic pressure and therefore generate more pressure. Here's where that comes into play. So the left ventricular pressure has to be more than 80 millimeters of mercury because that's how much is sitting on top of the aortic valve. The right ventricular pressure exceeds the pulmonary trunk pressure, but that's only about 10 millimeters of mercury. So there's a 70 millimeter of mercury difference in pressure that needs to be generated for these two sides to both work. And that actually gets back to the question, right? So let's say we have a left ventricle that's damaged and it's not as good at exceeding this pressure. That doesn't mean that the right side compensates for it, unfortunately. That would be awesome, but that's not how it works. So ventricular systole is just during the time which the ventricles are contracting, blood is actually leaving. So once the pressure in the semilunar valves is overcome. And the blood that's ejected per side, not total, is between 70 and 80 milliliters. So this is referred to as the stroke volume. Now, stroke volume is going to change depending on your activity level. Excuse me, yawning. So, at rest, meaning what you're doing right now, so just chilling, not actively exercising or anything like that. At rest, your stroke volume is about 60% of the end diastolic volume. So that's standard. The amount that actually manages to fully leave the heart, we call the ejection fraction. So it's the fraction of the total blood that ended up in there that managed to leave. And the amount remaining in the ventricle at the end of systole is referred to as the end systolic volume. So that means that the heart isn't perfectly efficient. It doesn't move 100% of the blood that it accepts out in one cardiac cycle. So there's always a little bit left over after the ventricles have contracted and done their job. So also at rest, the end systolic volume is about 50 milliliters. Now this can change with contractility. So contractility is not speed, it's how hard the heart is beating. So the vigorousness of the contraction of the ventricles is really what that means. So there's a lot of things that can change contractility. One of them is hypercalcemia, so too much plasma calcium. Another one is outside electrical impulses, so things like defibrillators or electrical shock, as well as catecholamines like epinephrine and norepinephrine. So if you think about a time when you were sympathetically activated, so maybe you got really scared or startled, you probably felt your heart thudding in your chest as well as speeding up. That thudding is an increase in contractility. So the goal there is to move more blood per beat, meaning increase the stroke volume in addition to increasing the heart rate. Okay, so ventricular diastole, we've got that short period I mentioned of isovolumetric relaxation, and that's going to go on until all the valves basically change pressure enough to open or stay shut, depending. So the valves remain closed until the ventricular pressure drops below atrial pressure, but the semilunar valves during this time are still going to stay shut. So the AV valves open once pressure up here, boop, boop, is higher than pressure down here. And then we've got passive filling proceeds until atrial systole starts the process over. So here we get into cardiodynamics. So I just mentioned things like end systolic volume and diastolic volume, stroke volume, ejection fraction. If you figure in those volume changes and add time, you can generate information about the heart that tells you about its efficiency and function. That's what cardiodynamics is. So cardiodynamics are movements and forces generated by the heart and their outcomes that are measurable. So cardiac output is, on its face, pretty simple. It means how much blood is the heart moving per unit time. So if you multiply heart rate times stroke volume, you get how many milliliters the heart is ejecting per minute. So for example, if the heart rate is 80 beats per minute and the stroke volume is 70 milliliters per beat, you just multiply those two and you get 5.6 liters per minute. So the next case study activity is going to ask you to manipulate some of these figures. So you'll have to practice with this math, which should be helpful because then when you have to actually do the math on the next test, it won't be unfamiliar to you. You'll have done some practice problems before. Okay, so cardiac output is this equation, but hidden in here, there are more terms, right? Because stroke volume, how do you calculate that? Well, you take the end diastolic volume and you subtract the end systolic volume, because that's going to tell you how much managed to leave, right? You could also express this as ejection fraction. So if I asked you to tell me cardiac output, I could ask you to calculate stroke volume by saying the heart received this much blood and the ejection fraction was 70%. So then if I told you it was like, you know, let's say the end diastolic volume was 100 milliliters and the ejection fraction is 70%, find the stroke volume and the cardiac output, you would just multiply 70% times 100 and you'd get 70 milliliters. That's an example. So what affects heart rate? Well, autonomic innervation, I mentioned. So if you make the conducting system in the sinoatrial node more leaky, you move the peaks closer together and increase the speed. And if you make the membrane less leaky, you're going to move those peaks farther apart and decrease the speed. So this is direct autonomic innervation by the sympathetic and parasympathetic nervous system, but also hormones as well. So thyroid hormone can change heart rate, as you guys know now, as can catecholamines coming from the adrenal medulla. So what I'm doing right now is trying to remind you of how what you've learned previously relates to what you're doing now. Okay, so I mentioned autonomic innervation. Hormones are another example, and others. So we're going to talk about some just cherry-picked examples of these things that I've mentioned, but we'll go into a little bit more detail. So the vagus nerves, does anybody remember what cranial nerve that is? It says there on the image also. It's 10. That's what X means. The trigeminal nerve is 5. So autonomic innervation via the vagus nerves and the sympathetic cardiac nerves control the rate at which the SA and AV nodes are allowed to depolarize. So they have their own intrinsic rates. That's what automaticity means. They spontaneously depolarize. But if you change the leakiness of those membranes, of those cells, you can speed up or slow down. So let's do some more connector pieces. The sympathetic cardiac nerves are sometimes just called the cardiac nerves. So if I just call them the cardiac nerves and I asked you to identify which of these two things were sympathetic and parasympathetic, how would you make the connection that the vagus nerve is, well, which would you say it is? Is the vagus nerve sympathetic or parasympathetic? Anyone? Some folks are probably writing right now, so I'll answer. Remember from our discussions of the autonomic nervous system that the parasympathetic division has another name, and that is the craniosacral division of the autonomic nervous system. So there's two names for that part. One of them refers to its anatomy. So if you know that the vagus nerve is a cranial nerve, that suggests that it's part of the craniosacral nervous system, which means it is parasympathetic. So that's an example of dots I would expect you to connect on the final. We want to be integrating stuff that we learned previously with stuff that we're learning now, and I'm going to help you do that. So the sympathetic cardiac nerves are obviously sympathetic nervous system, right? And these are the ones that actually do synapse in the sympathetic chain ganglia. So where does this control originate from? Well, as you know, most of the cranial nerves are concentrated in and around the pons and medulla, and their nuclei are as well. So in the medulla oblongata, we've got a cardioacceleratory center and a cardioinhibitory center. And each of these are in populations of cell bodies that are in the medulla oblongata and right next to each other. So these have feedback on each other, as you might imagine. So both autonomic nervous system divisions innervate the SA node, the AV node, and the atria. But if you look very carefully, there is more robust sympathetic innervation of the ventricles. And this is making sense because the ventricles are responsible for moving blood into the system and to the lungs, respectively. And so in a sympathetic nervous system event, when you're trying to fight or flee, one thing that you want to do is make sure that you're pumping blood as efficiently as possible. So blood equals oxygen and oxygen and nutrients equal get away or fight successfully. So another reason that the ventricles receive more robust innervation is so that they can get that direct hit of catecholamines, and that's going to increase both their rate of contraction, but also their contractility, so how hard they're contracting. Okay, so autonomic reflexes. You do have some mechanisms in place that make sure that, for example, your breathing and your heart rate are matched, or at least as matched as they can be. You also have reflexes to make sure that your heart rate increases momentarily when you, for example, change body position. So you have baroreceptors and chemoreceptors. Both of those are in your carotid sinus, which is right in here. And they're also in the aorta, so there's aortic bodies, but the primary ones are in the carotid sinus. So these are going to monitor stretch in those vessels, which is an indirect way to measure pressure. So the more stretched a vessel is, that means that the blood is pushing on the walls of that vessel harder, and that's going to be an indirect measurement of blood pressure. There's also something called glomus cells in the the carotid sinus, and those glomus cells detect oxygen specifically. So, for example, when you go from laying down to sitting up, your heart actually has to work harder to redistribute blood because you're changing its position relative to gravity. So it's harder to pump blood straight up when you're standing versus horizontally when you're laying down. So how do you not pass out every time you sit up from a laying down position? Well, the loss of pressure and the rapid gain in the need for it is detected by your autonomic nervous system, and then you get a little brief sympathetic impulse to speed your heart up enough to increase your blood pressure to prevent you from losing consciousness when you stand up. If you stand up too quickly and you outrun that reflex, that's when you stand up and feel lightheaded. So autonomic tone, which is the sort of average rate of depolarization of your autonomic nerves, is what determines heart rate, and then you can make little tweaks up or down depending on your need. And then someone's asking, so when this fails, that would cause orthostatic hypotension? And the answer to that is yes, it would. But usually, so it depends on the underlying etiology though, so I'm going to put a little asterisk on my answer for you. Because we're dealing with reflex arcs that involve sensors in the blood vessels. Hold on, I'm going to sneeze. Woo, I managed to keep it quiet. Hooray. So as I was saying, thank you. Thank you for the blessing. I tried really hard not to deafen all of you by sneezing directly into the microphone. So changes in blood gas and pressure are sensed here. They're sent to that cardioacceleratory and cardioinhibitory center in the medulla oblongata. And then you have interneurons processing that information. And then you have efferent impulses coming down from the brainstem. So there's multiple moving parts, which means that orthostatic hypotension is the outcome of a problem, but you cannot be sure which exact problem it is without doing additional testing. So you wouldn't, for example, know whether it was the heart failing to respond to those signals, or the signals failing to reach the brain, or whether the brain was just having a dumb moment, for example. So that would require additional inquiry, basically. Oh, actually, you just made me think of a really good example. So one consequence of starvation is orthostatic hypotension. And in that case, in anorexia nervosa, for example, one of the consequences of prolonged bouts of not eating and disordered relationship with eating and food is you get electrolyte dysregulation in the extracellular fluid. So you start getting low plasma calcium. And typically due to aldosteronism, you end up with high plasma potassium, hyperkalemia. And that changes the heart's ability to contract and the heart's ability to respond because you get permeability changes. So orthostatic hypotension is something that you see in anorexic inpatients a lot, and that one is related to ion dysregulation. So the cause can be a lot of different things. Okay, so let's come back. So I asked you a question about this very thing in the beginning of this, just to kind of see where everybody's mind was at, but now we'll address it directly. So remember, our pre-potential is this little drift towards threshold, but you can make this last longer or shorter, right? So the normal sinus rhythm set by the sinoatrial node is time 0 to time 0.8, which again, remember, 0.8 seconds or 800 milliseconds is the time it takes for a cardiac cycle. So that works perfectly. So if I wanted to make these two peaks closer together, I would want to make this line steeper, right? So instead of taking all this time to go this way, I want it to go like straight up. So as I mentioned previously, the autonomic nervous system acts on the pacemaker cells basically by changing the permeability. So it makes them leakier or less leaky, or it changes the permeability by acting on channels that oppose a particular concentration gradient. So let's say I wanted to move these further apart. So what happens with the parasympathetic stimulation is that we get release of, well, actually, you guys tell me, what do all parasympathetic postganglionic fibers release? Does anybody remember? I know it's been a while since we thought about sympathetic and parasympathetic nervous systems. So I'm trying to remind you because I want to help prepare you for the final in whatever way I can. So I'm going to make a note right now to include some of that on the case study activity so you have a chance to practice with low stakes as far as like easy points to earn. Okay, so they release acetylcholine, because remember all postganglionic parasympathetic fibers are cholinergic, and the receptors on those effectors come in various forms, but typically they're either nicotinic or muscarinic acetylcholine receptors. So if you're like, wow, I haven't heard those words in a while, consider revisiting them briefly. So parasympathetic stimulation is going to actually open potassium channels, which means that it's going to prolong repolarization. So we have voltage-gated potassium channels causing the membrane potential to fall back down, and then additional choline-gated potassium channels are opened, which keeps the membrane descending past threshold and down, so we hyperpolarize it, which means that it takes longer for the membrane to get back to where it was. Sympathetic division, we have catecholamines, primarily norepinephrine, opening sodium and calcium channels, and both sodium and calcium are higher on the outside of the cell than on the inside. So sodium and calcium are both going to rush into the pacemaker cells and cause the cell to not be able to repolarize as much, but also get back up to threshold much more quickly. So let's talk about the atrial reflex. So the atria receives venous return from your head, your pectoral area, and your arms via which vessel? There's two. This is the up one. All right, the answer is superior vena cava. And then everything else is drained by the inferior vena cava. So if those vessels are delivering more and more and more blood to the right atrium, it's going to be stretched more. The stretch causes an increase in depolarization likelihood in the SA node. So not only do they receive input via norepinephrine and acetylcholine, but they also are more likely to depolarize, and they depolarize more quickly if they are stretched. That's the atrial reflex. Basically, the idea there, and I'm saying idea, I'm using it loosely. The idea is that if you're experiencing increased venous return via the superior and inferior vena cava, that suggests that you're using your body in a more active way, which means that your heart rate is going to need to increase. So a reflexive increase in response to more venous return is built right in. Okay, other factors that affect heart rate. Well, I mentioned epinephrine and norepinephrine, obviously. And we also have, of course, thyroid hormone that are going to increase heart rate. And then venous return is initiating atrial reflex. So the more the atrium is stretched, the higher the rate will be due to depolarization of the SA node. Okay, so I mentioned the math component earlier, and if you're like, oh no, not math, don't stress. I'm going to give you nice round numbers, which should allow you to have pretty easy calculations for this stuff. So I'm not going to be like, end diastolic volume was 37.025 milliliters. Nah, I'll give you numbers that are integers. So stroke volume is the volume of the end diastolic volume that managed to leave the heart. So you can calculate it by taking end diastolic volume and subtracting from it end systolic. So since this is subtraction, a change in either of these is going to change stroke volume. So if EDV is bigger, but ESV remains the same, so more blood's returning, right? And stroke volume is the same, meaning the same work is being done, then you're going to have a larger or smaller stroke volume, right? And you can imagine other scenarios accordingly. So I could theoretically give you stroke volume in one of these and ask you to calculate the other one, for example. So what does end diastolic volume depend on? Well, I spent a lot of time this presentation talking about something I call passive filling. So passive filling refers to the time during which the AV valves are open and blood is flowing in to the atria and then through the atria down into the ventricles. So that's filling, and then filling time is the amount of time available to the heart to actually fill up. So think about this. If we know that most of filling is passive, it takes time to fill up the ventricles. What would happen to filling time? So as the heart rate increases, does filling time increase or decrease? Think about it for a moment and someone answer me. So would an increase in heart rate cause an increase or a decrease in filling time? That's the question. Decrease is correct. Very good. Yeah, so basically having a faster heart rate seems like it would be great, and it is adaptive to an extent. But if you don't leave enough time between beats to allow the heart to refill, that means you're not going to be able to move as much blood. So it's for this reason that tachycardia can be dangerous, because it means that the heart's not moving out very much blood because it doesn't have time to fill up with very much blood. So there's a relationship between filling and heart rate and the end systolic volume or the end diastolic volume. So venous return also affects this, obviously. So let's say you have enough time for the heart to refill, but your venous return is crappy for some reason. That could also decrease EDV. So venous return is caused by lots of different things. Skeletal muscle activity is a big one. Changes in cardiac output, blood pressure, and circulation patterns. So we'll talk more about that stuff when we talk about the vasculature itself. Okay, preload. Preload is a way to talk about how much the heart is stretched before contraction. So the heart is a little bit elastic, and similar to the SA node, how it will make an increase in heart rate if it's stretched with increased venous return. Likewise, if the heart muscle, which is a bag of muscle, if it's stretched with lots and lots of blood, so if filling is high before it contracts, it will contract more strongly. So this is called the Frank-Starling law of the heart, which just states that more blood in equals more blood out. So the more you fill your heart, the stronger it will contract to eject that blood. And this is based on that optimal resting length hypothesis from striated muscle. So remember the length tension relationship curve that I showed you last term? That was just saying that a slightly stretched sarcomere, so one that's at about 50-ish%, varies from striation to striation, so half-ish contracted is going to be able to generate a lot more tension than either a completely stretched out sarcomere or one which is already sitting at almost maximal tension. So what this means from a math perspective is that as the end diastolic volume increases, in a healthy heart, stroke volume increases also. So, end systolic volume. So after the heart ejects blood, how much blood is left over? How is that determined? One is preload. So due to the Frank-Starling law of the heart, if you have lots of preload, so a very stretched myocardium, theoretically, in a normal healthy heart, you should get an increase in stroke volume, and that's going to decrease your end systolic volume. Forcefulness of contraction in general will do this. So humoral agents, meaning ones that are in the blood plasma, you have positive or negative inotropic agents. So inotropy is affecting permeability to ions. That's what this means. So positive or negative ionotropic or inotropic agents are going to be humoral agents like hormones that can change the permeability of the contractile cells or the conducting cells to different ions, or the concentration of ions in the extracellular fluid. So I mentioned potassium and calcium previously are going to change that. So that's an example right there. And then, of course, the autonomic nervous system. So we have preload, which is how much stretch the bag of the heart is experiencing. We've also got afterload. So afterload is the pressure sitting down on top of the semilunar valves that must be overcome in order for ventricular ejection to occur. So I mentioned for the left side of the heart, that's about 80 millimeters of mercury, and for the right side, that's about 10. So increased afterload increases end systolic volume because the heart can't move as much blood because it has to push harder to get to that pressure at which the semilunar valves open. So afterload puts particular strain on the heart because the heart has to work harder to overcome it. So here's a nice summary slide that's basically just showing you, here's all the stuff that affects stroke volume. So the case study activity, at least part of it, because of course part of it's going to be other material as well. The case study activity is going to include asking you to think about all of these inputs to this equation and then make predictions about how various volumes will change and how the work of the heart will change if you tweak those various conditions. So these are things that a cardiologist is worrying about all the time for their patients. So if you go to a cardiologist because you're having heart issues, they're going to worry about how a change in one of these things is going to affect the rest of them. And you can also break this down into heart rate versus stroke volume. So this is the time component of the equation. And over here, we have the stroke volume component of the equation. So how much is the heart allowed to fill? What's the filling time like? How effective is venous return? How hard is it contracting? Are the contractions weak or are they very strong? And that's going to change ESV and EDV as well as afterload. So previously, we had a question about one side being damaged and whether or not the other one would compensate. And I mentioned heart failure, and I mentioned the lack of compensation creates pressure differences and pressure problems. So that person gave me actually a really, really nice prelude to what I'm going to talk about on this slide. Excuse me. So basically, congestive heart failure is when the heart fails as a pump. So for whatever reason, effects on any one of those influencing factors, you end up getting the heart not doing its job very well. So in America, the most common two causes of this are myocardial infarcts and chronic high blood pressure. So myocardial infarcts cause the heart to fail as a pump from the heart up, because when you get a piece of the myocardium that dies because it was denied oxygen, you don't get that back. So unfortunately, your heart muscle does not have regenerative capabilities. So your cardiomyocytes, your contractile cells, they're in G0, meaning that they have exited the cell cycle and they're done. Which means that if you lose them, they get replaced with scar tissue, which is collagen, and collagen is not contractile. So every heart attack one incurs, one's heart works less and less well. So you have a little patch of myocardium that can't contract, and that causes your end systolic volume to increase because your heart can't pump as hard. Chronic high blood pressure increases afterload. So if your arterial blood pressure is high, that means that the pressure required by your left ventricle to overcome systemic pressure is going to be bigger than 80 millimeters of mercury. So that means your heart has to work harder to get blood out, and you get it back up. Coronary artery disease can also cause this, as well as congenital defects and other problems. So here's where things get confusing. The left side of the heart delivers blood to the system. So left ventricle is going to pump blood up the aorta and out. If the left heart can't do that, blood backs up in the left, so you get blood left over in the left ventricle, and then you get blood left over in the left atrium, and then the left atrium gets a backup of blood such that blood is coming in via the pulmonary veins, but it's meeting up with more blood, which increases the pressure in the pulmonary veins. So that ends up giving you pulmonary edema, which is increased fluids leaving the capillary beds around each alveolus in the lung, and that puts water out of your blood and into your lungs. So edema is not great. It's an increase in extracellular fluid that is local. And when that happens in your lungs, it means you can't fill your lungs as much, which is very bad. So even though we don't think of the left heart as being associated with the lungs because it doesn't deliver blood to the lungs, if it fails, blood backs up into the lungs and gives you pulmonary edema. Oops, excuse me. Right heart failure results in peripheral edema, and that's for the same reason. So blood backs up from where it came from. So if your right ventricle isn't pumping effectively, you get blood not moving to the lungs and then backing up into the system, and that gives you peripheral edema. So blood backs up into your peripheral capillary beds, fluid leaks out, and this is generally noticeable, particularly in the feet and ankles, because they're at the bottom of your body, and gravity keeps the fluid pooling down there. So before we sign off for the night, I'm going to give you an example of CHF, just kind of as an applied medical case example. And this actually comes from an earlier experience. So in a previous iteration of my professional life, I worked for the College of Emergency Services, and my job was to teach anatomy and physiology to emergency medical technicians who wanted to be paramedics. So if you're not familiar with the difference, EMT and paramedic are very different certifications, with paramedics being a lot closer to doctors. They have more medical training and more emergency medical training specifically. But you have to qualify for paramedic school, and then you have to like get in and stuff. So that's kind of the deal there. So I was teaching this particular left-right heart failure thing, and I had one of my students that raised his hand, and he was like, oh, that explains the like Christmas and Thanksgiving phenomenon. And all of my students were like, oh, haha, yeah, it totally does. And I was like, I don't know what you guys are talking about. So here's the deal. The phenomenon he was describing was the following. On various holidays, typically Thanksgiving and Christmas, families who have their elderly loved ones living in retirement homes will go to the retirement home and pick up grandma or grandpa and either take grandma or grandpa to the house to eat dinner with everyone or take them out to dinner, right? In nursing homes, the diet of the patients is very strictly controlled, specifically to be low salt, because a lot of older Americans suffer from high blood pressure and from heart failure. And so you want to minimize the sodium in their diet, which helps control blood volume and therefore blood pressure. So what happens is when granny or granddad get the chance to eat non-nursing home food, they go gangbusters, because why wouldn't you, right? If someone had been telling you you can't have salt, and then suddenly you have a free day where you can have as much salt as you want, what are you going to do? Pig out on salt, right? I know I would. I love salt. So that generally happens in a lot of cases. And then, you know, everything's fine. Gathering comes to an end. drop grandma or grandpa back off at the nursing home. And then typically, you know, between 4 and 6 hours later, same family gets a call that says, oh, hey, your loved one was having difficulty breathing and we ended up sending them to the emergency room. And just time and time again, and my students who are EMTs, so driving ambulances, they just could track this pattern like clockwork. Like, oh, did you eat with your family 6 hours ago? Yes, what a surprise. So what happens is grandma or grandpa pig out on salt. Sodium from the diet goes into the blood. And that causes the movement of water from interstitial spaces also into the blood. So high sodium in the blood increases blood pressure because it increases blood volume. And old people's kidneys aren't great at pumping sodium out, so that sodium tends to stay there. And so if they already have a weak left heart, and now we have increased afterload, blood backs up the left side of the heart into the lungs over that 4 to 6 hours and gives grandma or grandpa pulmonary edema. So like family meant well. They were like, sure, have as much fried chicken as you want, Granny. I know you only eat bland food where we put you, but oopsie daisy, it causes a very serious medical problem totally by accident. And then I have someone in the chat saying they've seen this working in care facilities and didn't realize it was a known thing. I didn't either until my EMT students told me about it. But if you think about it, it makes total sense, right? So this reminds me of when my grandfather, before he passed away, was not allowed to have real salt anymore. And they give patients like my grandpa and the people that that I just described, they give them a salt substitute, which is calcium chloride, not sodium chloride. And I've tasted it. It does not taste good. So one night I went downstairs in my grandparents' house at like 2 a.m. for water, and I found my grandpa in the kitchen, and he was taking the salt container and he was filling his little fake salt shaker with real salt secretly in the night. And I totally caught him. But you know what, honestly, that would be me too. Like, I really like salt, and you can take it away from me with much difficulty. So, okay. Thank you everybody for your attention. I'm gonna sign off now and get to work converting these and posting them for you, which is why we did this recording. Yeah, I agree. Person who said YOLO, YOLO, related to salt specifically, among other things. Okay, so I'm gonna go post these videos for you guys now. I'll send you a notification when that is completed, and hopefully this will help get us caught up. I'm not certain whether or not the next Zoom session is gonna be recorded like this one, but I suspect that it will, so just plan on that unless I say otherwise. Okay, everybody, thank you so much for your attention. I'm gonna end the meeting now. Have an awesome night.